Imagine walking into a modern emergency room.
Oh, high stress, monitors beeping everywhere.
Right, exactly. The medical team is moving with absolute precision, and the terminology they use to describe the trauma in front of them sounds like this flawless, highly engineered code.
It really does sound like its own language.
But the thing is, the very words dictating those split-second life or death decisions, they're actually forged by, like, 16th century anatomists breaking the law and ancient Roman texts based entirely on dissecting pigs.
Yeah, which is just wild to think about today.
It is. So, okay, let's unpack this because our stack of sources for today's deep dive completely shatters that illusion of anatomical perfection.
It really does.
We are looking at medical texts focusing on the trunk of the skeleton, specifically the roots costo, sterno, and pelvi.
And tracing the history of these terms, it reveals that the human blueprint we rely on today is actually the result of a 1,000-year-long, incredibly messy, rough draft.
Messy is definitely the word for it.
It is a profound evolution, really. When we look at the core medical vocabulary for the human trunk, we're relying on terms that were inherited directly from classical antiquity.
Right.
We have costo, deriving from the Latin costa for side or rib. We have sterno, from the Greek sternon, referring to the chest or like something spread out flat.
And pelvi, from the Latin pelvis,
Yeah.
which translates literally to a wash basin.
Exactly. But for centuries, the application of these classical terms to actual human bodies was, well, it was riddled with foundational errors.
Much of that traces back to Galen in 2nd century Rome. Going through the historical sources, it's wild to realize that the most authoritative voice in medicine for over a millennium was legally barred from dissecting human cadavers.
Yeah, Roman law strictly forbade it.
So Galen mapped his understanding of the human skeleton by dissecting macaques, pigs, and dogs.
He had to rely entirely on proxy anatomy, and that created this massive anatomical echo chamber.
Because he was just assuming it all mapped one-to-one, right?
Right. Galen would dissect a pig, observe how its sternum was segmented, and then apply that directly to his human texts. But animal sternums segment and fuse very differently from human ones.
I mean, obviously because of the mechanical demands of walking on 4 legs versus standing upright.
Exactly. Yet because Galen's texts became unquestionable medical dogma, a physician in the 12th century would look at a human patient, use the term sternon, and literally picture the skeletal structure of a pig.
Which is just terrifying from a modern perspective.
Yeah.
And it wasn't until 1543 that the texts finally caught up with reality, thanks to Andreas Vesalius.
Vesalius was a game changer.
He essentially broke the rules by performing direct human dissections at the University of Padua. Publishing De Humani Corporis Fabrica, Vesalius corrected, I think, over 200 of Galen's anatomical errors.
Yeah, a massive undertaking. He was the one who finally gave structures like the sternum their human-verified descriptions.
But even then, knowing what a bone looked like didn't solve the linguistic chaos that followed.
Right. No, not at all. Vesalius bridged the gap between the classical root words and actual human observation. But by the 19th century, medical knowledge was expanding so rapidly, and the terminology was entirely localized.
I found that part of the research so fascinating. Trying to navigate the 19th century medical landscape sounds like trying to navigate a sprawling international city where every single neighborhood uses a completely different coordinate system.
And makes up its own street names as they go.
Exactly. A doctor in Paris might have 5 different regional terms for a specific section of the rib cage, while a physician in Berlin used an entirely different set of Latin or vernacular names for the exact same bone.
It makes you wonder how collaborative research was even possible back then.
Right, like having 10,000 different charging cables for a single phone.
It was incredibly inefficient. The rapid advancement of surgical techniques and pathology in the late 1800s required a universal standard.
Because if you were publishing a breakthrough in thoracic surgery, you needed absolute certainty that a surgeon in another country knew exactly which bone you were cutting.
Precisely. And that standardization finally arrived in 1895 with the Basel Nomina Anatomica, or BNA.
They essentially audited the entire medical vocabulary and slashed tens of thousands of regional synonyms down to just one official Latin term per structure.
Yep. The BNA and its later iterations culminating in the Terminologia Anatomica in 1998 cemented words like costa, sternum, and pelvis as the definitive, fixed roots used globally.
We finally had a unified coordinate system for the human body.
Which is crucial.
And now that we have that universal language established, looking closely at the literal framework of the chest, The ribs reveals that the simple root costo covers a highly complex mechanical system.
It really does. We aren't just looking at a static cage of 12 identical struts.
Right, the structural differences between the ribs dictate everything from how we breathe to how a doctor diagnoses trauma.
The architecture of the rib cage is, honestly, a masterclass in balancing protection with dynamic flexibility. The ribs fall into 3 specific anatomical categories based on how they anchor to the front of the body.
Okay, let's break those down.
Sure, so ribs 1 through 7 are the true ribs, or vertebrosternal ribs. They attach directly to the sternum, each utilizing its own individual strip of costal cartilage.
Then below those, we have ribs 8 through 10, which are the false ribs, or vertebracondylar ribs.
Right, and their cartilage doesn't reach the sternum directly.
Instead, they sweep upward and fuse into the cartilage of rib number 7, creating this shared flexible bridge.
Exactly. And finally, ribs 11 and 12 are the floating ribs, which only anchor to the spine and the back and have no anterior attachment whatsoever.
So as a doctor, why does it actually matter if a rib is true or false? Does that change how a patient is treated?
It absolutely does. The reason for this specific staggered architecture comes down to the mechanics of respiration, but it also affects palpation and how fractures behave. If every rib were a true rib, solidly anchored to the sternum, the chest cavity would be a rigid box.
You wouldn't be able to breathe.
Exactly. By having those false ribs share a cartilaginous margin and the floating ribs free at the front, the lower rib cage can expand laterally, like a bucket handle swinging upward. This allows the diaphragm to contract and the lungs to expand fully.
It's a really elegant mechanical setup. But because the ribs rely so heavily on that flexible cartilage at the front of the chest to maintain movement, it creates a specific vulnerability.
A huge one, yes.
The area where the hard bony rib transitions into the flexible cartilage is called the costochondral junction.
And that transition zone takes an immense amount of repetitive mechanical stress. Every single time you take a deep breath, cough, or twist your torso, force is applied across the costochondral and costosternal joints.
Which brings us to a wildly counterintuitive study from the sources. We've all seen the scenario, right? Someone clutches their chest in sudden, sharp pain, and the immediate assumption is a cardiac event, heart attack.
Of course, that's always rule number 1.
But there's this highly cited 1994 study by Disla and colleagues in the Archives of Internal Medicine. They evaluated patients arriving at the ER with non-cardiac chest pain, and they found that roughly 30% of those patients actually had costochondritis.
Almost a third. To break down that term structurally, you have costo for rib, chondro for cartilage, and the suffixinitis for inflammation.
So it's literally just a localized inflammation of those exact flexible junctions we were just talking about.
Exactly.
It's incredible to think that nearly a third of the ER chest pain in that cohort was essentially inflamed rib cartilage, and the pain is highly localized. A doctor can often reproduce the exact sharp pain just by palpating or pressing on specific points along the sternal border.
It highlights how the root costo constantly competes with cardiac terminology in a high-stakes differential diagnosis. The clinical challenge there is that the sensory nerves supplying the chest wall overlap significantly with the pathways carrying visceral pain from the heart.
Oh, so the brain literally gets confused.
Exactly. The brain struggles to pinpoint whether the danger is deep within the cardiac muscle or just superficial, sitting right at the costochondral junction.
Before we move off the ribs entirely, I noticed a really fun linguistic crossover in the etymology notes. The medical term costal meaning, related to the ribs, and the geographical word coastal, referring to a shoreline, they share the exact same Latin root.
Right, costa, meaning side.
Yeah, it's such a great visual.
The semantic logic translates perfectly there. Just as a shoreline forms the protective boundary, or side, of a landmass against the ocean, your ribs form the protective boundary of your vital internal geography.
And all of those protective boundaries, the true and false ribs, they all have to anchor to the center of the chest. The sternoroot, representing the breastbone, is often visualized as a single, solid shield.
But the texts show it is a composite structure with a surprisingly complex biological timeline.
Definitely.
The sternum is actually composed of 3 distinct segments. You have the manubrium at the superior end, the elongated body in the middle, and the xiphoid process at the inferior tip.
And they don't develop at the same rate, do they?
No, they don't.
Here's where it gets really interesting, especially with that bottom tip, the xiphoid process. The sources detail how this specific structure undergoes a remarkably delayed ossification. For decades of a person's life, it remains largely cartilaginous. It often doesn't fully turn into solid bone until a person is in their 40s.
It is a biological late bloomer. The mechanism behind this delay is rooted in endochondral ossification, which is just the process by which a cartilage template is gradually replaced by bone.
Right.
But cartilage, unlike bone, is avascular. It lacks a direct blood supply. The xiphoid process sits at the terminal end of the sternal blood supply network. So because it receives vascularization so late in the developmental timeline, the calcification process is incredibly slow.
Which leads to a phenomenon the clinical literature informally calls xiphoid-related anxiety.
Right, yes. Very common.
You can just imagine a patient in their mid-40s. Perhaps they're losing a little weight or just pressing on their upper abdomen, and suddenly they feel this hard, rigid lump projecting near their stomach that they've never noticed before.
And the immediate terrifying assumption is a tumor.
Exactly. But it is just their xiphoid process finally popping up.
The physician simply has to explain that the patient's skeleton has finally completed a localized 40-year-long maturation process. It's completely normal.
Beyond those developmental quirks, the sternum acts as the primary mechanical barrier in critical care. Right. The phrase median sternotomy is ubiquitous in cardiac surgery.
It is. Splitting the sternum longitudinally has been the standard access route to the heart since the 1950s.
But breaching that barrier comes with a severe physiological toll. The sternal bone marrow is highly vascular once mature, but healing a completely bisected bone in an area that constantly shifts with breathing takes 6 to 8 weeks of rigid stabilization.
And the sources emphasize the risk of mediastinitis, which is a deep sternal wound infection. It occurs in about 1 to 3% of these surgeries.
And while 1 to 3% seems statistically small, mediastinitis is a catastrophic complication.
Because the infection sits directly over the newly operated heart and within the highly porous bone marrow of the sternum, it carries a high mortality rate.
And this is the physiological rationale behind sternal precautions, right?
Sure.
Patients are instructed to avoid any eccentric pulling, so no lifting heavy objects, no pushing out of a chair using their arms.
Exactly. The integrity of the sterno framework dictates the entirety of their recovery.
We see that same structural reality in emergency resuscitation, too. In CPR, the sternum is the precise physical landmark for compressions. And doing CPR correctly requires immense force.
It does.
The data shows that in patients who are successfully resuscitated, fractures of the ribs and sternum are exceedingly common, occurring in over half of the cases in some studies.
It really forces us to confront the mechanical limits of the human body. The rib cage is designed to be flexible for breathing, but it is definitely not designed to withstand rhythmic, high-velocity compressions.
Fracturing the bony matrix is often the requisite physical cost of maintaining artificial circulation.
And the trauma applied to the sternum has also been at the center of how emergency medicine protocols evolve.
Oh, like the seatbelt sign.
Yes. When seatbelt laws became universal, the nature of car accident trauma shifted entirely. Instead of the chest impacting the steering wheel, patients presented with transverse sternal fractures caused directly by the restraining force of the seatbelt.
Initially, the trauma protocols were highly rigid. The assumption was that the kinetic energy required to crack the sternum must have also caused blunt cardiac injury beneath it.
Right. Therefore, any patient with an isolated sternal fracture was automatically admitted to the hospital for intensive cardiac monitoring, just across the board.
But the clinical data eventually challenged that assumption. Emergency medicine researchers analyzed thousands of these cases and found that if a patient had a normal electrocardiogram, an ECG upon arrival, and no other systemic injuries, the isolated sternal fracture almost never progressed to a delayed cardiac event.
So the protocol had to change. Routine cardiac monitoring for isolated sternal fractures was deemed low yield and unnecessary if the initial ECG was clear.
It is a prime example of medical practice having to untangle structural trauma from visceral trauma based on hard data, rather than assumed anatomical causality.
Exactly.
And if the sternum shows us how modern data forces trauma protocols to evolve, moving down to the base of the trunk to the pelvic root reveals an area where our reliance on anatomical terminology led an entire century of obstetrics down the wrong path.
The pelvis is arguably the most complex and contested of the 3 skeletal regions we're analyzing today. Starting with the etymology, 16th century anatomists adopted the Latin pelvis, meaning wash basin, because the bony ring cradling the abdominal organs visually resembles an upturned bowl.
But unlike the wash basin metaphor, it is not a single solid object.
No, not at all.
The pelvis is a composite ring formed by the fusion of multiple distinct bones, the ilium, the ischium, the pubis, alongside the sacrum and the cossagex at the posterior.
And they remain somewhat pliable, not fully fusing into a rigid structure until late adolescence. It is also important to clarify the terminology itself here.
Right.
The root pelvi and its anatomical landmarks apply identically across sexes. While we often discuss morphological variations like the wider, shallower gynecoid pelvis more commonly seen in females versus the narrower android pelvis more common in males, those are morphological spectra.
They aren't fixed defining features of the terminology.
Right, exactly.
And I want to look closely at that morphological spectrum, particularly regarding childbirth, because it introduces the most significant historical debate in our sources.
It's a huge one.
If we treat the pelvis as its literal translation, a fixed, measurable basin, and we know a baby's head has a measurable circumference, it seems like simple geometry. You should theoretically be able to measure the mother's pelvis to predict with absolute certainty if a baby can safely pass through the birth canal.
What's fascinating here is that for decades, the global medical establishment operated on exactly that geometric logic.
Wow.
The practice was known as X-ray pelvimetry. Physicians would take radiographic images of a pregnant woman's pelvis, carefully measure the internal bony diameters, and compare them to the estimated size of the fetus.
It sounds so logical on paper.
It was heavily relied upon, particularly for complex scenarios like breech presentations, to decide whether a vaginal delivery was anatomically safe.
But the sources indicate this practice has been almost entirely abandoned today. If the measurements were accurate, why did the geometry fail?
Because the geometric logic fundamentally misunderstood the biology of childbirth. X-ray pelvimetry treats the pelvis as a static, rigid wash basin. But childbirth is a highly dynamic biomechanical event.
Right, things are moving.
During pregnancy, the maternal body releases a hormone appropriately named relaxin.
Which softens the connective tissues.
Exactly. Relaxin increases the laxity of the pelvic ligaments, particularly at the symphysis pubis at the front and the sacroiliac joints at the back. So the bony basin literally expands and shifts under pressure.
Oh, and furthermore, the fetal skull is not a solid sphere either.
Yeah.
The cranial bones are separated by fontanelles, those soft spots, that allow the skull to mold, overlap, and actually reduce its diameter as it navigates the birth canal.
Exactly. So the static X-ray was measuring a state that wouldn't actually exist during the dynamic pressures of labor.
It was essentially useless.
Precisely. And the definitive proof came in the year 2000 with the publication of the term breech trial in The Lancet, along with subsequent Cochrane reviews.
What they find.
The randomized clinical data showed that utilizing X-ray pelvimetry did not reliably predict which women could achieve a safe vaginal delivery.
Because it couldn't account for the flexibility of the ligaments or the molding of the skull.
Right. And the clinical consequences of relying on that static measurement were actually detrimental.
Wait, detrimental, like it made things worse.
Yes. The data revealed that using pelvimetry significantly increased the rate of surgical interventions, specifically cesarean sections, without yielding any parallel improvement in newborn survival or health outcomes.
So it was artificially diagnosing anatomical incompatibility.
A century of obstetrical practice was essentially built on the flawed assumption that the classical root word, the fixed, rigid wash basin, was an accurate mechanical model for the human body.
And once the randomized trial data caught up, the practice had to be completely dismantled.
It serves as a stark cautionary tale in modern medicine. There is a massive, highly consequential gap between what makes intuitive anatomical sense and what is actually clinically predictive in a dynamic biological system.
So what does this all mean? We started this deep dive looking at three ancient inherited root words: costo for the ribs, sterno for the breastbone, and pelvi for the basin of the pelvis. We trace them from Roman texts and animal dissections through to the establishment of a universal medical language. But digging into the sources reveals that these terms are not just vocabulary to be memorized. They are the literal framework for how we manage human survival.
Absolutely.
We see it when a physician has to differentiate the mechanical inflammation of costochondritis from a lethal cardiac event. We see the physiological toll of breaching the sternobarrier in open-heart surgery and how trauma data forces us to constantly update our assumptions.
It's all connected.
And we see how treating the pelvis as a static geometric object led obstetrics astray, reminding us that the body is a dynamic, living system.
They are the foundation of high-stakes clinical reasoning. But I want to leave you with one final, sobering detail from the sources that perfectly encapsulates the fragility of our anatomical mastery.
But what's that?
It comes down to the simple act of counting. We've established the complex architecture of ribs 1 through 12. But structurally, the very first rib sits exceptionally high, tucked tightly beneath the clavicle, or collarbone.
Which means on a standard anterior X-ray, it is frequently obscured by dense bone and overlying tissue.
Exactly. Because that first true rib is so difficult to visualize radiographically, it is astonishingly easy for a radiologist or a surgeon to misidentify the second rib as the first when counting down the chest wall.
And if you start counting from the wrong structural landmark,
The entire coordinate system collapses.
wow,
The medical literature documents cases of wrong-level thoracic surgeries occurring simply because of this counting error. A surgeon might operate on the wrong vertebral segment or the wrong intercostal space because the anatomical map they were using was shifted down by a single hidden rib.
just from a simple miscount.
It is a striking reminder that no matter how universally standardized our terminology becomes, no matter how perfectly we define costo, the application of that knowledge is only ever as reliable as the fallible human interpreting the image.
The ultimate blind spot in the blueprint. We desperately want the human body to behave like clean, predictable engineering. We want the root words to point to absolute truths.
But they don't.
No, from 2nd century proxy anatomy to shifting trauma protocols to counting errors in a modern operating room, medicine remains an ongoing, imperfect translation between the rigid names we assign to things and the dynamic reality of flesh and bone. Thank you for joining us on this deep dive. Keep questioning the systems around you, and remember, the most complex mysteries aren't always in a textbook. Sometimes they're functioning right inside your own chest.